One thing that you can have a look at if you think that the lats are contributing to a lack of thoracic rotation is popping your hands out in front and putting your lats on a little bit more stretch and having a look at that if that's very different. So keeping your nose in line with your thumbs and going around. Similar for Sam, but if it was a whole lot less than what it was with his hands across his chest, we might think that his lats may have some tightness. They come right down onto that thoracolumbar fascia and they can certainly affect how much you're rotating as well. So the idea is that we want the athlete to be able to do most of their rotation through their thorax, so they're not having to rotate through their lumbar spine, because your lumbar spine's not designed to rotate. We want to make sure that the athlete's doing most of their flexion and extension from their hip, so we're not having to do as much flexion and extension through the lumbar spine. The lumbar spine is our load transfer. We want great movement above, great movement below. So for instance, you might have a swimmer getting back pain, hasn't got enough thoracic range of motion and is rotating through their lumbar spine and jamming that up all the time, or a water polo player that's swimming and then having to come up into extension rotation, not enough thoracic rotation, that's really jamming up their facet joints in their lumbar spine all the time as well. So the third element of assessing above and below the back that I'll look at is hip extension. So come along onto your belly for us. Can assess this in Thomas test position, but often if their backs are still a little bit sore, it's a whole lot easier to lie them down onto their tummy and just do a nice passive hip extension test. So Sam, I'm going to put my hand on your bottom here, just see how much movement you've got going back. Stay as relaxed as you can for me, and having a look at how much hip extension Sam's got and looking at comparing that to the other side as well. And certainly if Sam's got a whole lot less on one side than the other, and that's the side of his back pain, I might be thinking he's still hanging on through his hip flexors through this side. He needs hip extension to be able to return to running if he's an AFL player, if he's a hockey player, and not jam himself into hip extension when he's doing that. So we're trying to get good free easy movement below the spine, lumbar spine, good free easy movement above the lumbar spine, so that we don't get excessive stress on the tissues, okay? So we're going to leave Sam here for a moment. I'm going to show you what I'll tend to go to when I'm treating to get rid of some psoas tension. And if we can get rid of some psoas tension by gently looking at doing some mobilisations through the attachment through L1 and 2, how much we can change hip flexion, how much we can change hip extension and thoracic rotation. So it's a lovely big muscle that has a big compressive effect across the lumbar spine that often when we release off, we can get really big changes in range of motion above and below, but also we often will get some positive changes when we retest hip flexion or straight leg raise, because certainly the back's not being as stressed when we're holding that psoas tone, like we were talking about in the first practical when we were looking at finding an exercise that might turn this off. So here's a manual therapy technique that may help that. So often when someone has had some back pain, they've got a decent amount of erector spinae muscle tension that we want to get rid of first to be able to sink down onto those L1-2 transverse processes. So doing some gentle soft tissue work through erector spinae so we can try and get rid of a little bit of that tension that's hanging on. We've targeted that with exercises we've given Sam after the first consultation to try and down-regulate that, but we're going to give him a little bit of help today as well. We don't think we need to tape him afterwards because he's improved a lot because we've unloaded his tissues, and so therefore getting rid of a bit of tone that's hanging on and helping him out, and then enabling him to do the exercises that we've figured out last time that have helped to keep that away is a good way of keeping that upregulation of erector spinae or psoas tone down and helping the athlete as we go. Manual therapy, as you know, is also a really lovely time to be able to keep educating the athlete about their back pain and answer their worries with their head in the hole where they're not looking you straight in the eye. So certainly first line treatments are education and giving the athlete exercises, but manual therapy as an adjunct to treatment is really powerful, and as clinicians we know this. We enable athletes to move a little bit better, and it gives them a chance to have a chat as well, which can't be underestimated. So in how I release psoas off, I'm going to find the L1 transverse process, so sliding off the erector spinae, getting onto L1 transverse process, And I'm oscillating back and forth on that. Sorry, Sam, it's not real comfortable, is it? Because we're pushing on bone. Yep. And I'm just waiting for that to give a little bit. So I'm telling the patient it's still going to be pretty tender because I'm pressing on your transverse process the whole time. But as it's giving a little bit, we're getting rid of a little bit of psoas tone by doing that. And I find this a much more effective technique than going through the front and doing a myofascial release through the psoas muscle belly. And that's really quite uncomfortable for patients as well, particularly if they're suffering from some back pain and they've got some guarding through their abdomen. So down onto L2, transverse process.